So today we are going to discuss the valves and their diseases. Okay, first off we have mitral valve and mitral valve stenosis. Mitral stenosis is almost always either rheumatic, or it is because of age, or it is congenital. Pathogenesis: in rheumatic mitral stenosis, the mitral valve orifice is slowly diminished by progressive fibrosis, calcification of the valve leaflets, and fusion of the cusp and subvalvular apparatus. Mitral valve orifice is normally about 5 cm square in diastole, but can be reduced to less than 1 cm square in severe mitral stenosis. The patient is usually asymptomatic until the orifice is less than 2 cm square. As stenosis progresses, left ventricular filling becomes more and more dependent on left atrial contraction. There is dilatation and hypertrophy of left atrium, and left atrial pressure rises, leading to pulmonary venous congestion and breathlessness. Any increase in heart rate shortens the diastole when the mitral valve is open and produces a further rise in left atrial pressure. Yes, this is the point. This is where we are told we have to give them beta blockers. Situations that demand an increase in cardiac output, such as pregnancy, exercise, also increase left atrial pressure and are poorly tolerated. Okay, and then we have atrial fibrillation. It is very common due to progressive dilatation of LA. Its onset often precipitates pulmonary edema because the accompanying tachycardia and loss of atrial contraction leads to marked hemodynamic deterioration and rapid rise in left atrial pressure. In the absence of atrial fibrillation, a more gradual rise in left atrial pressure may occur. In the presence or absence of atrial fibrillation, pulmonary hypertension may occur, which can protect the patient from pulmonary edema. Pulmonary hypertension leads to right ventricular hypertrophy and dilatation, tricuspid regurg, and right heart failure. Fewer than 20% of the patients remain in sinus rhythm, but many of these have small fibrotic LA and severe pulmonary hypertension.